when those hard times come, I try when I can to see that we're just all working together. We all have the same goal. If we just keep working together, if we keep at it, we can get there.
Welcome to Believe in Progress, the American Association for Cancer Research Foundation podcast. Join us and be inspired by the incredible stories of those who have faced cancer with strength and resilience, and the medical professionals who are working tirelessly to find new treatments and ultimately a cure. Believe in Progress isn't just about the science of cancer. It's about the human side of this disease. Together, we can make progress in the fight against cancer and bring hope to those who need it most. How do cutting-edge cancer research and compassionate patient care intersect to transform lives? That is the question we're going to answer in this episode of Believe in Progress with our special guest, Dr. Kris Ann Schultz. The podcast is brought to you by the American Association for Cancer Research Foundation, and I'm your host, Mitch Stoller, Chief Philanthropic Officer at AACR. At the AACR Foundation, we believe that research is the key to ending cancer, and every breakthrough begins with scientists dedicated to pushing the boundaries of what's possible. That's why today's episode is such an important one. We are so honored to be joined by Dr. Schultz, a pediatric oncologist and a leader in the field of DICER1 research in rare childhood cancers. Dr. Schultz is not only a scientific director of cancer and blood disorders at Children's Minnesota, but she's also the principal investigator of the International Pulmonary Blastoma DICER1 Registry and the founder of the International Ovarian and Testicular Stromal Tumor Registry. Dr. Schultz is on the front lines of pediatric oncology, driving groundbreaking advancements in the early detection and treatment of DICER1-related tumors and rare childhood cancers. As the scientific director of cancer and blood disorders at Children's Minnesota, Dr. Schultz has dedicated her career to uncovering life-saving surveillance strategies for individuals at risk of developing aggressive cancers. Her work is not just changing the way we understand pediatric cancer, it's extending lives and offering hope to families across the world. Thanks to her work, hospitals like Children's Minnesota are now implementing surveillance strategies that prolong lives and change the future of pediatric cancer treatment. But Dr. Schultz's story is about more than just research. It's about passion, resilience, and the power of science to save lives. Whether you're a patient, a caregiver, a medical professional, or someone passionate about supporting cancer research, this episode will leave you inspired by the incredible progress being made by people like Dr. Schultz in the fight against childhood cancers. In this episode, you'll hear how Dr. Schultz's early career and personal drive led her to pediatric oncology, the groundbreaking discovery she's making in DICER1 research, how her work is shaping the future of pediatric cancer treatment and surveillance, and why early detection through research-driven strategies is critical for saving lives. How you can support cancer research that leads to real life-changing impact. If you want to hear how science, passion, and perseverance are reshaping pediatric oncology, this is an episode you don't want to miss. So, Dr. Schultz, such a great honor to have you here today. Really appreciate your time.
Well, thank you so much, Mitch, for that beautiful introduction. I'm really just so grateful and so honored to be talking with you today about DICER1 related cancers. I'd just like to start by highlighting that everything that we're going to talk about today, these exciting research advancements, these are really made possible by patients and families, folks who so generously shared their medical journeys, their stories, their tissue samples, in some cases blood samples, to really put this all together as a team effort to advance research for these cancers. So I'm just so very grateful to be a part of it, and especially grateful to all those many patients and families who have really made this possible.
Oh, that's fantastic. First question for you, though. Are you in the Twin Cities, somewhere in the Twin Cities? Is that where you're
I
located?
am. Yes, Children's Minnesota is located right here in Minneapolis and St. Paul, Minnesota. Our healthcare system serves kids throughout the upper Midwest.
You may be familiar with the NMDP, the National Marrow Donor Program. I did some work for them with their foundation, which is now called Be the Match Foundation, helped them with the naming of that. I have great fondness for the Twin Cities.
Wonderful. Well, thanks. We hope to welcome you here sometime soon.
Absolutely. Well, take us back to the beginning and what first drew you into the field of medicine, specifically pediatric oncology.
Oh gosh, that's such a great question. I just love kids. I think it's all about kids. And the idea that pediatric oncology combines both kids and science, holistic care for all kids and families, I think that's really the draw. When I think about pediatric oncology, I think it's this chance to combine just the love of kids and working with these families with the idea of advancing science, a chance for us all to work together. And it's also really a chance to see love in action. I mean, there's just nothing like seeing a family and even a whole community and the whole world really come together to support individual kids and families when they're faced with a cancer diagnosis.
Was there any defining moment, like said, I've got to go into this area?
Gosh, I think there were just so many defining moments, but it was absolutely direct interactions with kids and families. As I was thinking about what part of medicine to go into, it was absolutely all some very special families that just and our paths just intersected it in pretty amazing ways. So again, I just feel so grateful to those families for influencing my own journey in those ways, and for all the many things that I've learned from so many families along the way, and so many kids.
It's gotta be quite emotional and really heartwarming to deal with families and little ones as well. Is there like a formal definition for what a pediatric oncology or a pediatric cancer patient is? It it's up to a certain age level?
Well, I think that definition varies to some degree. Different people choose different cutoffs. In our clinic, though, we care for both kids from birth until even through young adulthood. And the age at which that transition happens really depends in some ways on the type of cancer. There are certain cancers that, even when occurring in younger people, are more often seen by adult oncologists. And then having adult oncologists as a key part of the team is really important. And likewise, even in young adults and even in older adults, I think sometimes when cancers are more characteristically pediatric cancers or things that we see more often, then that really truly collaborative approach is important. So I don't think there's one certain age cutoff. I think there's more a discussion about what the individual treatment plan requires and how he can best intersect all the psychosocial and supportive care needs of that individual and that family with what the treatment plan needs to be. So in many cases, especially along those age borders of young adulthood, it's really a collaborative approach with adult medical oncology and pediatrics.
Interesting. So earlier in my career, I worked for Livestrong, and we did a lot of work in young adult cancer, and there's still a lot of issues with people treating young adult cancers. Do you actually follow through with some of your pediatric patients that have kind of graduated up to the young adult status?
Absolutely. So, in a few different senses, I think this DICER1 research that we'll talk about today really spans across the age spectrum. So, both through our research and to some degree through clinical care, we're involved in the care of individuals throughout a wide age spectrum. Certainly, our research involves individuals of any age. But then I think the other component of that is really survivorship care. So, when I think about our clinical team here at Children's Minnesota, we have lots of folks that are working on caring for folks throughout their treatment journey. But then, as people are off of treatment and extending into that survivorship phase, it's really important that they still continue to receive survivorship care and that they receive ongoing education about their diagnosis. So I think it's both pieces. It's both the treatment during the acute phase of treatment and deciding what the most optimal treatment will be. And then it's also about supporting individuals throughout their survivorship journey.
When you talk about survivorship care, could you just tell the audience a little more about, like, just articulate a little more about what that is and what that looks like?
Well, that's a great point. So we strive during treatment to give the least toxic and yet most effective treatments that we can for an individual with an individual cancer. That's absolutely a part of the plan from day one. But yet at the same time, we know that many of the treatments that we give can have both short and long-term side effects. During cancer treatment, one of the focuses is about, of course, curing the cancer and trying to help keep individuals as healthy as we can during that process and optimizing their physical function and their overall general well-being during that treatment journey. An important part of treatment is also extending that care beyond the actual acute treatment period into this period that we call survivorship, where we're really looking out for some of those long-term care issues, trying to monitor for and make sure people know their own risks for any long-term side effects of treatment. And really trying to address those as best we can. Because really the ultimate goal is not just cure, but the best well-being for that individual person throughout their entire lifespan.
Absolutely.
So I think that's a component of what we do with these early diagnosis things that we'll talk about today with DICER, trying to detect these tumors in their earliest and most curable forms so that we can really minimize the toxicity or the side effects associated with therapy and make that outcome or that prognosis as good as optimal as we can. But it's also a part of care for any child or adolescent or young adult or older adult treated for cancer, that we think about not just the short-term outcome and cure for cancer, but also optimizing their long-term overall well-being, really from a multidisciplinary and holistic perspective.
So as a practicing oncologist, you're also a great researcher as well. Is it hard to transition?
Well, I think in my view, it's really tremendous honor. And I think there's just a huge amount of synergy between those clinical components and those research components. A lot of the questions that we're asking in this research space first came to me as questions from patients or from parents. I mean, I think about one of the projects we're working on related to circulating tumor DNA. We're asking the question, could you use a blood sample to try to detect this tumor, or to it both upfront, or to detect this tumor as it first starts to regrow in the case of a relapse or recurrence? And the first person to ever ask that question that I was in a room with was a parent who said to me, "You're telling me that you can't quite tell based on this MRI if the tumor is back or if that's an area of scar tissue. Isn't there any blood test that could tell you that answer?" Um, that was the first time I'd ever thought about circulating tumor DNA. It was a parent who asked that question. Now, other people had thought about that before, but it was the first time I ever thought about applying it to this set of DICER1 related cancers. So I think those questions that patients ask, that parents ask, really help drive a lot of the research that we do. So I view those two things as very synergistic with each other. And really, of course, patients are the inspiration for all of this, they're the reason to do any of this research.
Patients and families, sounds like they contribute a heck of a lot to your work, besides the motivation and the inspiration to do what you do. But, even having a parent just ask you a question like that, oh, gave you an idea to further explore another area.
Mhm.
Do you see that a lot with families?
Absolutely. I think that so much is made possible by the direct contributions of patients and families. And that, just as you said, Mitch, you said it so well, extends from inspiring all of this in the first place and inspiring everyone's passion and drive to continue this work and asking the best questions. And even the very concrete things like the donation of tumor samples. So when someone has a surgery, it's possible to take some of that leftover tumor sample and use some of the fixed tissue, some of the tissue that's preserved after that surgery for certain studies, or use some of the tumor that's frozen after one of those surgeries for certain things. And sometimes, even if we know ahead of time that a surgery is happening for one of these very rare cancers, we can even collect fresh tissue or viable, growable tissue from some of those surgeries. Now, we have to know ahead of time so that that can all be planned, but we can potentially collect growable tissue, viable tissue that we can then test different treatments against, so that we can hopefully make progress as quickly as possible, especially for some of these very rare diseases where we don't already have these existing models and large databases of research to try to understand what works the best. So I think there's huge contributions of patients and families. I really can't say enough how much patient and family contributions mean to this research, and really to the whole field of cancer treatment.
That's awesome. That's great. So let's talk a little bit about DICER1 now. I'll be honest with you. So I've been 11 years here at AACR, and as you know, our scientific meetings are pretty cool, and we have lots of really interesting topics and workshops and meetings. But I'd never heard of DICER1 before until I started researching you and learning a little bit more. But could you tell our audience all about DICER1 and kind of work you're doing?
Oh, great. Thanks for that question. So, DICER1 is a gene. We all have two copies of this DICER1 gene. But the function of DICER is really to serve as a bit of a dimmer switch on cell proliferation through regulation of what we call microRNAs. And so it's not too surprising that if somebody has one copy of DICER1 that doesn't work quite as well as it should, or perhaps doesn't work at all, that there might be some alteration of how cell proliferation is regulated. So you think about very tiny babies in utero and how they grow so quickly that during that first 9 or so months. And then kids still grow pretty quickly during that first year of life, but maybe not quite as quickly as they'd grown the first those earlier 9 months. And then growth slows down a little bit. Your kids don't grow quite as quickly between age 1 and age 5 as they did between 0 and 1. And eventually we do stop growing. We're not all 27 feet tall. So DICER is one of the things that regulates that cell growth and proliferation and helps turn down the right growth factors when it's time to do that. So again, it's not too surprising that if something wasn't regulating quite as well as we would like with DICER, that might increase someone's risk for certain specific cancers. And actually, we know that most individuals with DICER1 variation, most individuals who are born with one copy of this gene with a change in it, are actually healthy. They might have minor findings such as thyroid nodules or lung cysts, but they don't necessarily develop some aggressive form of cancer. But they are at increased risk for certain specific cancers. And one of the goals of this research is to say, if this is going to occur, we want to find it as early as possible so that that tumor can be potentially removed even just with surgery alone, without needing chemotherapy. So really, early detection is a key part of what we do. And so we're working on these new surveillance guidelines that I hope that we'll talk a little bit about today to say, okay, if we identify that somebody's at increased risk for one of these DICER1 related cancers, what strategy do we propose so that we can, if a tumor is going to occur, we can detect it as early as possible? So early detection in the tumor's most curable form is really our goal there. And that means identifying who might be at risk for these tumors so that we can test the right folks, so that we can do the right chest x-rays for the kids that need it and not do chest x-rays for everybody, just the kids who may benefit from that. Or same thing with abdominal ultrasounds or pelvic ultrasounds at certain ages, especially in childhood. And thyroid ultrasounds also for adults. So that's clearly one of the goals of this research is early detection for individuals that we can identify as being at risk. And I think that's a really neat part of medicine, thinking about this pattern recognition. Pattern recognition is a big part of why many people went into medicine in the first place, kind of that aha moment of medicine. I see it. I see this connection between this part of the family history and what I'm seeing now with this young child. So I think there's a great power of pattern recognition when it comes to things like hereditary risk for cancers. DICER1 is a great example of that. But it's not only about pattern recognition, it's also about getting the word out so that people know that, so that they have that information to use to make sure they get the best care they can for them and for their kids.
Can you identify at-risk kids with early detection, or are there some things that are like diagnostics or something that you're using for this?
Yes, absolutely. So in 2018 originally, the registry that you mentioned at the beginning released the first ever set of surveillance guidelines for individuals who have this DICER1 variation identified for them or for their family members. And so that first set of guidelines took all the data that had been collected up to that point in the registry and said, okay, based on what we know about when we're seeing these tumors occur, here's what we think is a reasonable starting place in terms of when these young kids should have chest x-rays, or when these girls and young women should have pelvic ultrasounds to look at the ovaries, or when both young girls and young boys should have kidney ultrasounds, or when adults should have thyroid ultrasounds.
How young are these kids when they would get these x-rays?
Age of diagnosis for PPB, which is the most common lung cancer of infancy and early childhood, but still a very rare tumor. Those kids are mostly diagnosed under the age of 7. So our early surveillance for those at-risk kids really focuses on kids under the age of 8. And then for girls and young women at risk for those ovarian tumors, the age is a little older. So we do recommend pelvic surveillance that extends over a wider age range during that time of risk.
Do their parents see like a change in their wellness so they even think to come visit with you? Or
Yeah, one of the keys here is family history, individuals knowing their family history. So if there's something in the family history that can then trigger testing for this particular gene. And then individuals who have this particular gene then can lead to testing for other members of their family and can trigger this algorithm or these recommendations for surveillance. Our goal, really, to your point, Mitch, is to detect these tumors before they cause any symptoms so that we can take care of that often with surgery alone before those tumors really cause a problem.
Mhm.
Of course, that's not always possible. Those kids aren't always identified in advance, or young women with these ovarian tumors are not always identified in advance. So some of the other things we're working on certainly focus on the development of novel treatments or more targeted treatments to address these tumors when they can't be treated just with surgery alone. But I think it's really a two-prong approach. We think about prong number one being early detection. How can, just to your point, how can we identify these families, identify these kids so that they can benefit from early detection? And and we've seen that work. I've cared for some of those kids whose tumors are found before they go on to cause more trouble, before they need chemotherapy or radiation or these other treatments.
Is there a particular story that you could tell me about?
This is the story of an amazing young woman. She was 33, and she'd heard that had this ovarian and testicular stromal tumor registry. So she approached us, and she said, "Hey, it was many years ago, but I had a Sertoli Leydig cell tumor. I had this type of ovarian cancer that you were talking about in this presentation. You know, if there's," and she says, and this sentence makes her the hero of this story. Truly, she said something like, "If my old tumor sitting in a jar somewhere could help somebody else, of course, I want you to have it." You said, "Well, great. I'm happy to talk with you about this study. We would love to have you participate." And so this amazing and truly heroic young woman participated in the study. And it actually had turned out that since the tumor had been removed so many years ago, it had already been destroyed. It was no longer in the lab. But we were able to do some testing to show that she did have this DICER1 variant. She didn't have any other reason to know that was the case other than this history of having an ovarian tumor when she was a teenager. But she had 3 kids, was pregnant with her 3rd child. And so we were able to then test the kids and identify for that that for her youngest child, that he did then have this earliest form of this rare lung tumor. And really, he was able to have that then surgically removed before it caused any other trouble for him. And I'm so happy to say that he is now a thriving, happy, healthy, wonderful, amazing, charming 11-year-old who I just love seeing in clinic. And that story really taught me, and even his parents really just taught me this phrase that we still think about and use all the time, that knowledge is power. That if you know this information, it doesn't mean anything bad is necessarily going to happen, but it means you know what to look for. It means you know what action steps you can take to improve the chance of a good outcome.
Knowledge is power rings a bell for me because actually, when I was the chief executive officer at Livestrong, that was part of our manifesto. Knowledge is power, and there's so much truth to that statement, isn't there?
There really is, and I've seen it in action so many times. That's the family that first taught me that for sure. That really spurred our motivation to get that first set of DICER1 surveillance guidelines written, and really the ability to understand what we should do next has just continued to grow from there, culminating most recently in this latest set of DICER surveillance guidelines when we said, okay, now what? Now those first guidelines were published in 2017, 2018. How can we now analyze the data we've collected over that time period since? So just released now in Clinical Cancer Research in December of 2024, the latest set of DICER1 surveillance guidelines saying, okay, based on what we know now in 2024, 2025, here's how we would tweak those guidelines. We hope to make them a little better at detecting those tumors early. So, for example, we learned that some of those ovarian tumors were happening earlier than we had at first thought. And so we were able to decrease that age where you start doing pelvic ultrasounds, hoping to detect those ovarian tumors as early as possible. And then spreading the word with things like your podcast, Mitch.
Yeah.
We have a DICER1 scientific symposium and family meeting coming up in May. We work closely with our patient-parent advisory board to develop educational documents and to figure out how to really share this information so that everybody who needs this information can benefit from it.
I think you were involved with some of our working groups and some of the pediatric working groups. Has that community been helpful for you?
Yeah, absolutely. I really loved coming to AACR in April and presenting with that panel on the topic of pediatric cancer. And then also, just as you're saying, the development of these surveillance guidelines across a variety of childhood cancer predispositions.
Hmm.
So it's been great to be able to synergistically use our registry experience with DICER to help work with work with the AACR working group to develop those broad-based surveillance guidelines for a whole wide variety of childhood cancer predispositions.
What are your biggest challenges?
One of the challenges here is the rarity of this tumor. Um, so there are questions that we want to ask that the data just won't let us ask yet. So I think that speaks to the power of everyone who's interested in being involved in this. If this rings true for you as people are hearing this podcast, we hope that they'll contact us and consider participating in this research, because I think that putting everyone's story together really can make a difference, especially in such rare cancers.
Hmm.
So I think numbers is really the one that numbers relates to sample size for statistical calculations when you want to look at if this, is this treatment better than this treatment, but it also relates to having the tissues that are needed to drive forward work on the laboratory end. So I think that's also a challenge.
Right, how big's the registry?
The registry now includes about 1,600 individuals from many countries around the world, from more than 600 institutions, but still over 40 years, that's still a fairly small number of people. So that really highlights the rarity of these tumors.
Yeah, so the idea is let's get more people on the registry, right?
Yeah, I think that's a really important part of this. And one of the reasons I'm so excited about outreach like your podcast, Mitch, is that we want everyone who's interested in participating to have the opportunity to do that, to share their ideas, to share their journeys, to share their questions. And then we hope to share any information we learn back out in venues like this and venues like the family meeting or the scientific symposium, patient education documents, manuscripts, so that really people who need that information, treating healthcare providers and patients and families, can have access to it.
How old is Dicer, if you will?
DICER itself has been around for a long time, but the science article by Ashley Hill and colleagues that first described DICER1 in relationship to PPB, its first known relationship to human disease, that was just in 2009. And highlighted just really that original research was just based on findings from a small handful of families, and really has led to this immense expansion in our understanding of cancer and how cancer develops, and I hope how cancer can be more effectively treated in the future. So that article for me, that first article in Science in 2009, Hill et al., that really, I think, highlights just the power of everyone working together in a rare disease space, the power of patients and families and researchers and clinicians working together to try to understand cancer itself and how best to treat it.
Is it emotional to work with families? You're dealing with some sensitive issues here, right? How do you balance that?
Well, you're absolutely right. It's very emotional. There's a lot of love involved, I think, um, in all of this. But I just when those hard times come, I try when I can to see that we're just all working together. We all have the same goal, and we may not be there yet. I know we're not there yet. Um, but I do think that if we just keep working together, if we keep at it, we can get there. And that hope, um, I think, is what makes the rest of this possible. They're like awful, terrible, no good, very bad days.
What keeps you motivated on your hardest day?
These amazing kids and patients, kids, young adults, and their families, getting to see love in action, getting to see the impact that one person can make. Each patient, each individual, um, when they share their journey, when they share leftover tumor samples or blood samples, there's just a tremendous impact of each one of those acts on the whole field of cancer research. Um, I just talked to the most amazing young woman today about her journey and just the tremendous impact that she's had on the field of cancer research. And while I wish we were already there, I wish already that I had these answers so I could just treat her with the right thing, with the
Mhm.
right magic bullet that would make her tumor better. And I can't do that, even though I so wish that I could. That's not where we are today. But I know that by working together, that's where we're going to be. And I think that's the main message from my standpoint, is that, do I want it to already be here? Absolutely. Like, I wish these questions were already answered so we could just go give the treatment that needs to be given to everyone that needs it. And the truth is, we're not there yet. But I do think that if we all work together, I think we will.
Yeah, we'll keep pushing.
Mhm.
What's one misconception about pediatric cancer research that you would like to correct? I've heard a lot about some misconceptions about pediatric cancer research, like some in industry don't want to, perhaps get behind it because it's not a big enough base, if you will. Is there anything that comes to mind?
I don't know if it's misconception specific to pediatric cancer, but I think when people think about cancer research, they probably think about like something that's being done in a lab, and they probably envision a person in a white lab coat with a pipette and a test tube, and they're pipetting DNA from one tube to the next. And that is a piece of cancer research. But I guess that what I would say is that cancer research is really a team sport. It's what we all do together. So our cancer research, for example, of course, involves patients and families, and that means kids and adolescents and grown-ups and their families. And it involves the whole multidisciplinary team of healthcare providers, from physicians and nurse practitioners and nurses and physical therapists and the whole cadre of folks that care for people clinically. And then it includes researchers, and that means clinical research coordinators and clinical research assistants and laboratory folks and postdocs and PhDs in every discipline. And it's all of us and what we each bring that makes a difference. So yes, does it involve labs and test tubes and pipettes? Sure, but that one image does not define cancer research. It's really what we're all doing together.
I always want to work harder after having the opportunity to meet somebody like you who's so dedicated to what you do, and it puts a huge drive in me to want to succeed and be better. And we're going to do our best to get the word out for you. And in our show notes, we'll let people know where they can go, and we certainly will promote this on social media, as well as I think your team will do the same. But it's just been a wonderful honor for me to spend a few minutes with you and learn more about all the work that you're doing, and more importantly, you're a great role model for many.
Oh, well, thank you so much. I really appreciate your kind words and this opportunity to share this research on this podcast. And again, I just want to say what a difference that individual patients and families make in this effort, and to thank you for spreading the word along with us. It's a great team effort.
My pleasure. Thank you so much.
Thank you, Mitch.
Dr. Schultz's work is a powerful example of how research saves lives, not in theory, but in practice. Her commitment to pediatric oncology, early detection, and life-saving surveillance strategy is shaping a brighter future for children and families worldwide. If this episode inspired you to help in the fight against cancer, Here's how you can help. Donate to support pediatric cancer research at AACR.org. Learn more about DICER1 research and how it's changing lives. Share this episode to spread awareness about the power of cancer research. Dr. Schultz, thank you for the incredible work you do every day. Your passion and dedication are an inspiration to us all. To our listeners, thank you for tuning in to Believe in Progress. Remember, cancer research saves lives, and your support makes a difference. Subscribe to the podcast, share this episode, and stay tuned for more inspiring stories. And remember to believe in progress in the fight against cancer. This episode was produced by CollegeCast LLC.